continue with the debate, and the next topic of debate is iStent. We have Dr. Prasad and Dr. Sahebaan.
Lunch after breakfast.
Hi, thank you all. Thank you so much. First of all, I should thank Dr. GC. You just made my life a lot easier. So I really don't need to speak. No point speaking when you're speaking against, not against, but when you're debating with Dr. Saiba, because you're never going to win that debate, are you? I'm going to keep this on a very light level. And I'm sorry about the quality of my slides. They were all done on my phone last night. So, yeah, some old habits I have. So, can I just go back again? Sorry. Can you go back to the first slide? Okay. So when you talk about a new generation every 3 years, besides kids, you see in glaucoma, you've seen these devices come over the years, whether it was the Solex Goldshan, whether it was the Express, whether it was SciPass, of course, and a host of other ones. And at every given point in time, at least in my career as a private practitioner, as a non-reliable private practitioner, it's nice to see that there's something new coming up. It's very convincing. It looks like the best thing on the planet at that point of time. Till 3 years later, there's a new device that comes in, and before you know it, the first one is gradually being phased out. Before you know it, from a point of view of not probably being able to follow the literature as aggressively as I should. Depending on what your personal preferences are, you'll find both these devices attractive. The iStent on the left and the fancy little bike on the right. Some people would find both attractive, some people would find none, and some would probably find one. The common factor in this slide is that both these devices cost the same. The fancy bike on the right and the little iStent on the left. Both would end up getting you to the same endpoint. You don't really need that fancy bike. You can still do it with a different sort of bike if you have. And then the same rule applies for iStent where we are using it, isn't it? Because if you are going to use an iStent in a patient with an early glaucoma or with an ocular hypertension, just because you're going in for a cataract surgery, is it not possible to get that same endpoint without having to put in a fancy little bike in his eye? So, if you look at the evidence for iStent, I looked at the Cochrane review, and one of the things that comes up is that the evidence for treatment with iStent is actually low quality, which may result in higher proportion of participants who are drop-free or achieve better control in the long, medium, or short term. And all this in this particular study, there were 7 RCTs which I looked at, all of whom were actually sponsored by Glaucos. So that's where we are with the evidence for the stent which has been around the longest. And all these devices, whether it was the little fancy bike in front, come with a risk, or the iStent later. We spoke a lot about the risk yesterday, whether it's occlusion, malposition, device not working, dislodgement. And coming back to what we were trying to say yesterday, that the aim of reducing the medication burden rather than absolute IOP is what is being told now. And is that really in line with the traditional aim of glaucoma surgery that I grew up with? In my mindset, no. I get the point with Dr. Saiba was saying yesterday that if there is an option available, we need to tell the patient. Fair enough. If you have an option available for an iStent while you're doing a phaco, sure enough, tell it. But just because let's not judge the patient if the patient can afford it or not. But in that same breath, that if the patient can, let's not judge that the patient is not able to get a preservative-free monopros or a preservative-free COSOP from abroad. If he's able to spend that 1 lakh, 1.5 lakh to get an iStent in the eye, he might be equally comfortable to get preservative-free medication, which might do the job. It might get us to the same endpoint. So that's where my take on the iStent is. I think there is definitely a role for it. There's definitely places where you can use it. I don't think there are definite places where definite places where you can't or you shouldn't be injecting these iStents, angle closure being for one. And And yeah, at the end of the day, it's going to be a philosophical discussion. Thank you.
Dr. Divishi and Dr. Harika, they're waiting for you for the hands session.
Okay, so before I start the debate, I think we are having a lot of discussion on fast progressors, slow progressors. So just off topic, I want sir and ma'am to correct me if I'm wrong. See, when we say a glaucoma is well controlled, we mean the glaucoma is still progressing at a rate of 0.6 decibels per year. So let's also understand that when we are putting in perspective where mix should be applied. A normal person who doesn't have glaucoma, they progress at the rate of 0.07 decibels per year. A controlled glaucoma patient will still progress at the rate of 0.6 decibels per year. And an uncontrolled glaucoma patient progresses at the rate of 1.7 decibels per year. This is just for clarity for people who don't really understand how to gauge whether the people are progressing or not progressing, when to intervene, when not to intervene. Ma'am, figuratively, do you think, am I close?
0.6 is
A
in
controlled glaucoma
glaucoma patient is a lot.
I would agree with the fast progresses, but controlled patients progressing at 0.6 decibels per year is not something that I am comfortable with.
So it should be lower.
It's lower.
Okay. So let's take that message home.
We see a lot of patients whose regression lines are flat, when they're controlled. So it's not that every patient progresses at that level.
So
Every controlled patient progresses at that level.
So, sir, will it be safe to say that if there is a person who's progressing at that rate, you would like to hike up or increment the treatment?
Yes.
Okay. Right. So I think that'll be a good take-home message for everyone, because that was also something that was gnawing at my head. Okay, coming back to the discussion, the debate, let me first make a disclaimer that I have no shares in the device. I hope they were paying me for the kind of criticism I'm getting, but I'm just doing this for the sake of the debate, and I have no financial interest. So again, like I said yesterday, we have no mix which is a foolproof thing for which patient. We still don't know. We have absolutely no evidence to suggest which mix is right for your patient. But I feel each one has its place when it's used in the right context and the right patient. And that is something that you will only know with experience when you're dealing more and more with your patients. You're seeing your own post-ops. In fact, I was telling ma'am, the only way to convince anyone, even if I want to go back home buying the idea that CAT is good for severe glaucoma, if I don't have enough evidence from an Indian study, I wouldn't be convinced. So anyway, we are still getting there. There will be publications in the future very soon. Now, also, since iStent is the most extensively researched device, this is probably the only mixed area where there has been a study which can predict the success of the device in the subsequent eye of the patient where you've already implanted it with one eye. There is no other mixed procedure which can predict that. So if you're doing KDB or GAT in one eye, you don't know if it's working in the other eye or not. Although this may not be 100% reliable, there is still some perspective that it puts into you, and also it makes it much easier to counsel your patients. So if an iStent has worked in one eye of a patient, provided the glaucoma is comparable in both the eyes, there is a 76% probability that it will work in the other eye as well. And basically, we also need to understand what you mean with success. So for me, if there is a pre-perimetric POAG with cataract, if I'm able to bring down the medications from 2 to 0 with an acceptable range of IOP, this for me still is success. Why? Because I have freed the patient of all the anti-glaucoma medications, which means no compliance issues, no side effects, difficulty, forgetfulness, all of that, which all is contributing to IOP fluctuations and probably glaucoma progression. So I'm freeing them of that. Let's also remember 60% of our glaucoma patients are suffering from dry eye disease, and after cataract surgery, it may leave them with an unsatisfactory visual and maybe even a sensational outcome. And what you're also doing by freeing them or prolonging the use of anti-glaucoma medication is you're making the conjunctiva more favorable for future TAB because these are lifelong glaucoma patients. And I would reserve a TM excision procedure for a little more advanced glaucoma. This is also a very interesting video that I took of a patient who was extremely confused about how many medications and how to put it. So it is a real challenge for patients. Let's not forget that. Now, having said it, iStent is only and only indicated in open angle glaucomas, mild and moderate glaucomas, and only FDA approved to be implanted at the time of cataract surgery. The patients in whom this will be my first choice will be patients who cannot be taken off the anti-glaucoma medications. Again, there is a publication only in this device which says it is safe to use it while the patient is on anti-glaucoma medications. Any young patients that I want to preserve the trabecular meshwork for future treatments, when Siddharth asked, what future treatment, what are you going to do with this? There is a lot. See, we didn't even have this device about 2 years back. We didn't have mixed 2 years back. That time we didn't care about the trabecular meshwork. Now we do. Tomorrow we may just care about even a millimeter more of trabecular meshwork that's left. There are treatments which are being investigated of TM-based drug implants. So you want to preserve the trabecular meshwork. You want to be most anatomically fair to your patient. Also, secondary glaucomas, wherein you know that the problem is obstruction of the trabecular meshwork. If you bypass it, it makes sense. And also in premium IOL. So it can be safely used with all premium IOLs. An advantage, you would not deny your patient who is an ocular hypertensive or a very, very early glaucoma. That is also another myth, that we deny all our patients of premium IOLs, even if they have absolutely no damage in the optic nerve. So it is safe to use even with toric IOL. So there are a lot of patients who have benefited with this. And when you talk about advancing technology, yes, it has evolved with time, but so has our trab, hasn't it? So have our tubes, so have our cataract surgeries from ECC to phaco now to MICS to whatnot, and even our IOL. So anything which is here to stay with evolve, and it should, because it is effective. That's why you're investing in an improved design. So yes, evolution has happened because it's here to stay. And also, iStent is the longest and probably the most extensively researched device. And believe me, 270 plus publications is not a cup of tea of a company to invest into. There have been fair studies also. And the longest follow-up so far that we have is also of this device, which is 7-year-old. And there have been consistent 40% IOP reduction, 60% drop reductions in these patients. And it is by definition the most truly minimally invasive, which is the most specific advantage of this, because you're saving the trabecular meshwork. By definition, it becomes a mix, what GC sir was saying. I'm sure he will not back me up with this, but I'm taking one of his comments for my favor. Also, combining iStent is possible when you're doing also in the future when you have viscocanelostomy, even eye-axis precision blade goniotomy is being tried because you have more trabecular meshwork to play around with. These combinations of MIGS are also possible when you preserve the maximum. And because there is least destruction, there is rapid recovery. You have that wow factor in the first post-op day, no hyphema, no inflammation, none of that. So especially with your cataract surgeons who are visually very demanding, maybe this is just the best fit for them. And the fewest complications, bleeding, maximum safety. It also, in my opinion, has the shortest learning curve. And although it may have looked very simple, it isn't. You have to have a rock stable hand, because in such a high magnification, any of the mixed surgeons would know, even a micro movement of your hand will actually exaggerate and you can injure a lot of structures. So over here, there is a surgery where, instead of the trabecular meshwork, the root of the iris is being excised. So there are more complicated procedures than iStent. And yes, over and over, we have talked about the cost, which I agree is a big deterrent. But also let's remember that a patient who is on maybe 2 to 3 glaucoma medications is spending at least about 7.7% per annum income of theirs in just the anti-glaucoma medication, which becomes comparable to a 1 one-time cost of iStent maybe over a couple of years. But in those couple of years, by making them medication free, you're giving them better quality of life, better 24-hour IOP control, visual stability, ocular toxicity, freedom, and also more suitable conjunctiva for TRABs. Also, insurance cover is something that we really need to intensify. And finally, I would rest my case by saying, like I said yesterday, there is no right or wrong. Glaucoma is so multifactorial and diverse that there is a place for everything. So choose the patient wisely. And it is a very individualized approach on choosing. The algorithm is very nuanced. It depends upon the patient's demands. It depends upon the target IOP you're looking at, the surgeon's comfort, your type of practice, and of course, the insurance cover. Thank you.
Thank you very much, Dr. Prashant and Dr. Saheba.